Thank you very much, Professor Kotsis Vasilius, for the invitation. I know ahead of schedule, so I will try to be synthetic and to address the question of renovascular hypertension. So there are in fact many causes of renovascular hypertension, but more than 95% are accounted for by atherosclerotic renal artery stenosis, a large majority, and then an increased proportion with fibromuscular dysplasia. And so I will focus on these two causes. First, atherosclerotic renal artery stenosis. Above a certain degree of stenosis, as you all know, there is activation of the renin-angiotensin cascade and a host of angiotensin II related effects in terms of vasoconstriction, renal sodium retention, aldosterone, vascular hypertrophy, SNS, and myocardial effects. And this explains why the clinical picture associated with severe renal artery stenosis is not only hypertension, but also alteration in renal function, potentially heart failure or flash edema. When to screen for ARAS? Well, not in all patients, as some young people do, but in oxalate-resistant malignant hypertension, in case of recent deterioration of renal function, especially after prescription of RAS blocker, new onset of hypertension after 50, kidney asymmetry, and very important, sudden unexplained pulmonary edema. And this is particularly true if patients have already other localization of atherosclerosis, and you can see here in such subgroups the prevalence of renal artery stenosis, which can be really very high. How to screen for ARAS? Well, the echo Doppler remains an excellent tool, and you can see here summarize the criteria in terms of peak systolic velocity and renal aortic ratio, but in many cases you will have to confirm, and the key exam to confirm are CT and MR angio, as already shown in this old classical study. The added value of captopril scintigraphy or test is dubious, especially in case of renal failure or bilateral stenosis. Then why to screen? Well, for much time, people screen because they think they should revascularize or stent renal artery. Now, as you know, it is more controversial and there is less enthusiasm. As can be seen in one of the numerous meta-analysis of randomized trial comparing revascularization with medical treatment alone in patients with ARAS, the benefit in terms of systolic blood pressure is not significant, or in some other could be marginal. There is, it is true, a slight decrease in the number of antihypertensive drugs, but no benefit in terms of renal function estimated by, let's say, an imprecise parameter such as serum creatinine. This is why in some centers they don't even screen anymore for renal artery stenosis. Well, I don't think it is justified. Because as already said in multiple review papers, these recent trials, even the largest show here, have limitation because they include often patients with mild unilateral stenosis, unlikely to activate the hormonal cascade, because patients were not optimized on antihypertensive therapy. There was a lot of crossover, and most importantly, especially in Astral trials, patient could be included only if clinician was unsure if revascularization would provide clear benefit. So the patient most likely to benefit were probably excluded from many of these trials. And so we have to rely on good observational studies. And earlier, Professor Kreuz has already highlighted the importance of observational studies when we have not other studies. And if I can summarize them in a nutshell here, it has been shown that patients with flash pulmonary edema, patients with moderate to severe, let's say moderate chronic kidney disease, or those with resistant hypertension, may benefit, sometimes even spectacular, from renal artery angioplasty and stenting, especially if stenosis is severe bilateral, and if moderate, if there is a high translational gradient. So few indication, but might be good. And in your estimation, you should also consider recent worsening of renal function, of worsening on RAS inhibitors, which are indicator of a good response. On the contrary, very old patient with proteinuria, diabetes, high risk of cholesterol emboli, low kidney size or high resistance index might not be good candidate. Maybe even more important, when we identify an atherosclerotic renal artery stenosis, you identify a patient at risk of diffuse atherosclerosis, and you should see global and control risk factors according to the established evidence. Because ARAS is in fact a severe condition with a high risk for mortality, which is already in this old study, was somehow between angina and colonic cancer. And this is explained in part by associated comorbidity, but also probably by systemic inflammation due to the renal artery stenosis itself. And so you should look for atherosclerotic lesion elsewhere, and especially for silent coronary heart disease in every patient, I think, with ARAS. This patient should quit smoking, benefit from low-dose aspirin, statin, antihypertensive treatment, particularly RAS blockade. And as you can see here, another interesting observational study, ACE inhibitors in such patients was associated with independently improved survival and even free survival, despite a mild rise in creatinine, which should not afraid people, while this was not the case for revascularization. So unless there is a bilateral stenosis, when it should be considered with caution or is contraindicated, in many cases of ARAS, ACE inhibitors or sartan might be very beneficial. Now, a few words about fibromuscular dysplasia, the second cause frequency of renal artery stenosis. You can see here on the upper left corner the iconic image of the string of beads. And in fact, the mechanism by which it elicits renovascular hypertension might not be the same as for ARAS, and this is still controversial, but I have no time to speak about this. But my message is more that there are different manifestations of the disease, and you can already here see to the right the focal presentation, and also that cerebrovascular arteries might be affected. And so FMD is an underestimated cause of stroke, not only of renovascular hypertension. More generally, we have learned that FMD is a systemic arterial disease, which happens mostly in women, but also in up to 20% of men, which may affect all arteries, at least middle-sized arteries of the body, and beside the stenotic lesion, can be in a number of cases at the origin of dissection, aneurysm, and arterial tortuosity. It is not such a rare disease because silent lesion of FMD can be seen in up to 6% of tentative kidney donors. So we should think to it. When to screen? Well, in hypertensive patients, especially women, less than 30 years, personally I would go up to 50, but this is what is in the consensus. Patient with grade 3 resistant or malignant hypertension, and we find sometimes FMD in patient referred for renal denervation. Certainly in case of renal artery dissection or infarction, you should look for FMD lesion elsewhere, and you can see here some more marginal of obvious indication, but this is a big picture. Also, based on our data from the European International FMD Registry and Initiative, we should consider screening for FMD in young women considering a pregnancy with unexplained hypertension, because if the lesions are not revascularized, there is an increased risk of gestational hypertension, preterm birth, and preeclampsia, but fortunately, low risk of dissection and aneurysm rupture. How to screen for FMD? Well, the authors of the consensus have gone for CTA, or in the absence of contraindication, MRE, because unless they are very expert people, the sensitivity of duplex ultrasound is too low and too operator dependent. Still, the latter has a major place, and we usually do it in parallel, and we can also use the peak systolic velocity and renal artery to aorta velocity ratio, but we should remind that the cutoff has been defined and validated only for ARAS. More specific is the turbulent color flow and the beading. This is almost for textbook. Then why to screen for FMD? The first reason is to consider vascularization and medical treatment. The second, to look for additional lesions elsewhere. I will go through this now in 2-3 minutes. Medical management, no firm evidence, but expert opinion. Antihypertensive treatment, especially again RAS inhibitors. Consider acetyl salicylic acid, especially in case of severe disease and cerebrovascular form, and certainly dissection. Quit smoking, because it was associated in some studies with an increased risk of FMD progression and aneurysm. For revascularization, the situation is much better than for atherosclerotic renal artery stenosis. In this Plouin meta-analysis, 36% of hypertension cure, but if you look at the younger patient below 35 years, new onset hypertension, you can have maybe 70% of a cure rate. So it definitely needs to be considered in this case. I would like to remind that based on authors' experience and case report, stenting should not be performed due to an increased risk of stent fracture or thrombosis with renal infarction, unless there is a per-procedural dissection, which is rare. And so the second reason to detect renal artery FMD, even if it does not lead to revascularization, is to find other lesions elsewhere. And in the best studies, such as the French profile study, also in our hands in Ferry, there are 50 or 60% of patients with lesion in another arterial bed than the renal arteries. It has been stated that regardless of initial site of vascular involvement, patients with FMD should undergo at least once a lifetime CTA MRA from brain to pelvis in order to detect additional FMD lesions, but more importantly, aneurysm or dissection, which may deserve follow-up or sometimes immediate management. So this is just to remind you about the European International FMD Registry and Initiative, now approximately 2,000 patients supported by the European Society of Hypertension. And this resource allows us not only to contribute to the description of the disease. Here you see in the first 1,000 patients, we define specific profile. For example, we confirm that patients with dissection, strangely, they are often men rather than women, but also to understand better the pathophysiology of the disease. This allowed us to contribute to a major GWAS meta-analysis performed by Nabila Bouatia-Nagy in Paris, which allowed to identify loci associated with the disease. And more recently, we performed a pilot study with Professor Mishak and colleagues and Rosa Maria Bruno on urinary proteomics, and we showed more than 300 peptides differentially expressed in FMD and control. And using this data, we constructed a classifier which allows to discriminate quite well FMD from control, but also patients with other cardiovascular or renal disease. And now we are trying to expand this in larger number and specific phenotypes of FMD or FMD-like. And this is why we need your help. As you can see, we are numerous, but I would like to add a second slide next time and benefit from your kind collaboration. Finally, If this was not too much and you still wish to know more about renovascular hypertension, I advise you to read this excellent review, which was an initiative from Professor Januszewicz, also with participation of his team and Dr. Canning, a young, excellent Irish vascular specialist, where you can find description and management of more rare cause of renovascular hypertension. Thank you very much for your attention. And again, thank you for the invitation.
Thank you.